Thanks, Nikki. Okay, so thanks for that introduction, Nikki. And before I get going, I just want to say that I am in no way as much of an expert on this topic as Dr. Battisti and Anne, but it is something that has come up a lot in recent months in my practice and has got me thinking about what are the barriers that exist in the system as it currently exists, and when we're in a situation where there isn't very much money around, how might we tweak what we're currently doing to better support people with sarcopenia through the cancer pathway, and particularly relevant to my role, the head and neck cancer pathway? Next slide. Thank you. So what is sarcopenia? Very briefly and quite basically, there's a lot of discussion about this in the literature. So keeping it simple, it's a muscle disease characterized by the association of low levels of muscle strength and low muscle mass. Sarcopenia is considered primary when it's age-related, or secondary when a specific cause is evident. And cancer patients are at risk of both types of sarcopenia, both because they tend to be older, and then both cancer and its treatment can trigger sarcopenia. And there is then also a crossover with cancer cachexia. So what do we know about sarcopenia and cancer more generally? So next one. So we know that the prevalence is between 22 and 38% across all cancer subtypes. It's linked to reduced overall survival, reduced disease-free survival, increased post-op complications, increased dose-limiting toxicities, and increased nosocomial infections. So it's certainly something that we want to be looking at, particularly when roughly a third of patients may well be affected, and it has such a big impact on their cancer outcomes. Next slide, please. So how does this link to sarcopenia and head and neck cancer specifically? So the prevalence rate, you click again. There we go. The prevalence rate is anywhere between 25 and 62% as it's reported in the literature. Next one. And it again is linked to reduced overall survival, reduced disease-free survival, increased dose-limiting toxicities, and then it actually is linked to increased pre-treatment dysphagia in the head and neck cancer population, and also to acute and late-stage dysphagia post-treatment. And obviously, where you have a crossover between sarcopenia and cancer cachexia, the involvement of dysphagia is likely to create a vicious cycle where a patient actually physically unable to eat or struggles, and that impacts on their nutrition, which then impacts on the sarcopenia or the cachexia. Next slide, please. So what does the literature tell us about treatment for sarcopenia? So a lot of this has been done in the non-cancer population. So, for example, Lou et al. Did a randomized control trial of 92 community-dwelling older people with sarcopenia. They received 6 months of therapy that included resistance and balance training, nutritional enhancement, and cognitive training. And at the end of that 6 months, 1/3 of the cohort were no longer considered to be sarcopenic. So there is potential to certainly improve the symptoms of sarcopenia, if not actually reverse it entirely, with the appropriate interventions. Next slide, please. So how does this relate back to cancer? So you can see on this chart an overview of some of the rehab that has been reported in the literature. So you've got progressive resistance training in colorectal and head and neck cancers, nutritional interventions in head and neck cancer and the non-cancer population, generic exercise programs. There's a systematic review done by Chung et al. In 2023 across all cancer subtypes, and then also in the non-cancer population. Combination of physio and nutritional intervention in the non-cancer population. And then there's a couple of case studies around the use of dysphagia therapy and nutritional intervention in lung cancer and head and neck cancer. Next slide, please. So what happens currently in the head and neck cancer pathway? So there would be normally pre-treatment or post-diagnosis and pre-treatment support, and then weekly follow-ups from a dietitian that might involve things like food fortification, dietary supplementation, and enteral feeding support, and then post-treatment reviews after that. And similarly for speech therapy, so pre-treatment and on-treatment, swallowing assessment, swallowing therapy, including prehabilitation, diet modification to support the maintenance of oral intake that is important to actually maintaining swallow function during treatment. And when I'm talking about treatment, I'm talking specifically about radiotherapy, curative radiotherapy for head and neck cancer, which typically is daily over a period of about 7 weeks. So the bit that is missing is the physical activity side of things primarily. That's fine, next slide. And we got the same picture as Anne. Celia et al. Did a study, a mixed method study into head and neck cancer and what are the barriers to increasing activity, physical activity in this population. And the first of those barriers was fatigue and pain associated with cancer and treatment, and pre-existing conditions that maybe affected mobility. Then there was a lack of intent, and this is something that was worthwhile going into a little more detail. So the patient cohort were of the opinion, generally speaking, that they already had sufficient physical activity levels. But actually, when this was cross-referenced with quantitative assessment of their physical activity, the cohort was actually deemed to have low to sedentary physical activity levels. So actually there was a mismatch between the patient's perceptions of their physical activity and what they were actually doing. Then they noted that there was a lack of social encouragement. So this population group found that they were generally not in social circles that tended to be physically active. So there was less of that social encouragement from family, from friends, to get active, to be involved in whatever sort of level of activity was appropriate to their sort of age and abilities. And then noticed also financial constraints about accessing activities, travel issues, trying to get to those activities, and then clashes with sort of work commitments, family commitments, that sort of thing, depending on the patient. Next slide. So this is possibly my most controversial slide, and it really is a combination of just my thoughts over these last few months about how we might tweak the system to better support people, particularly thinking that the patients with sarcopenia are likely to be on average older but may not be, and particularly thinking about the radiotherapy treatment pathway. So first of all, we have prehabilitation, and whilst pre-treatment speech therapy and dietetics has been available for quite some time, we are starting to see now some prehab clinics with physiotherapy involved, but these tend to be happening at the hospital centres. And the rationale for that is the patients are at the hospital anyway, so that's the best place to provide it. However, there is, as we know in the workup, so the time between diagnosis to commencing treatment can be very short, and there are a lot of other appointments that happen in that time period. So it's not an easy thing for people to be accessing. And I do wonder, and I'll come back to it later, whether hospital is the best location for those prehab clinics. In terms of the on-treat support, several years ago, when we first started working with our patients on a weekly basis during radiotherapy, something we actually started by offering it in the community. So we were doing it as home visits, and something that happened quite regularly was that we would go out to see a patient and they could easily fill an hour of an appointment with concerns that primarily didn't relate to anything to do with speech therapy. They were things that needed to be directed to the nurse or the dietitian or the oncologist. And if we ask patients, just wondering, why haven't you said anything? Did you forget? What's the issue? For the most part, the responses that came back was that when they are at the hospital, although there's that idea of a one-stop shop and that it would be easy to access, in reality, by the time they've travelled to the hospital, sat around waiting for radiotherapy, had their treatments, and then gone into clinic, they're not feeling well, they're tired, they're in pain, and all they really want to do is go home and curl up in bed. And so they don't end up making the most of the appointments that they have at the hospital. And they certainly weren't giving a full list of their concerns to our colleagues at the hospital, and they were really only coming out when we were going to visit them at home. And something else, just thinking about that older population, and particularly around trying to keep them mobile, trying to keep them eating and well nourished, is whether home visits would be beneficial to them in that time, for someone to actually physically go out and check how are they getting on, because our older population are far more likely to be living alone. And so actually, are they managing to keep up with doing their shopping, doing their food shopping when they're going through radiotherapy, or is that fatigue and pain becoming a barrier? And when you go into their home, are the kitchen cupboards bare? Is the fridge bare? And do they actually need some support around that? I'll come back to that bit a little bit later around some ideas. And then thinking about post-treatment activity, looking back at that study around the barriers that the head and neck cancer patients mention in relation to accessing physical activity. If anything, it's sort of post-treatment that we really need to be focusing on, because that's the longest time period for them, is post-treatment. And thinking about those barriers and the social barriers that they reported. Oh dear, sorry. The social barriers that they were reporting. Also then the travel restrictions, the financial restrictions. Would it be better to be putting people in touch with local places where they could be going to actually get engaged with physical activity groups? And could we be linking this back to the whole prehabilitation topic, that actually, if we looked at using some pre-existing systems that have already been set up for other population groups, so GPs have for several years now been referring into local gyms and leisure centres and what have you, for people to access subsidised physical activity as part of their medical care. And maybe we could look at something like that, where people are actually referred to the local gym, the local leisure centre, for prehab in terms of physical activity and post rehab, because actually that way, when they go to those sessions, they'll be meeting local people who may be experiencing very similar treatments, but hope that might stand a better chance of building those social relationships that might encourage them to go back to that physical activity when they finish their treatment, and whether it be worth sort of joining those two up and keeping it much more local. Then moving on to the next one, which is the comprehensive geriatric assessment. And it was interesting that this was mentioned by Dr. Patisi and Anne, and thinking particularly around the post-treatment pathway for these patients, and whether there would be benefit in something like a community ACP role in terms that could be available to support PCNs in supporting patients with cancer post-treatment, and using comprehensive geriatric assessment to actually highlight where the needs are and start putting in place local support measures for people. And that would of course include provision of social prescribing and use of the voluntary sector, and to link that back to that on-treat timing, whether it would be something that we could look at, or would it be beneficial to actually have a voluntary sector organisation supporting vulnerable patients going through radiotherapy, and actually being that person that goes in to the patient's home and checks up with them and sees how they're doing, checks that they're getting their shopping, checks that they're eating, checks that they're managing okay with the housework and things like that. Because actually for a lot of these patients, a care package isn't what they're going to be needing. It's a temporary issue. And actually the logistics of trying to organise that would be huge. But maybe some sort of voluntary sector support, who then had a link into the MDT to be able to report back to clinicians about any concerns they might have, might be a way of better supporting people without a lot of additional investment required. So those were just a few of my thoughts. So thank you for listening.